นะครับโดยได้รับเกียรติจากดร.อินวูงอัมนะครับก็ปัจจุบันท่านก็เป็นรีวิวเวอร์ให้กับ journal หลาย journal เลยไม่ว่าจะเป็น Journal of Oral and Maxillofacial Surgery หรือว่า Journal of Oral Implantology นะครับนอกจากนี้เขาก็เป็น Director ของการวิจัยของKorea Tooth Bank นะครับแล้วก็เป็นChairman เป็นประธานของ Implant Research Committee ของKorean Association of Oral and Maxillofacial Surgeons ด้วยครับผมSo welcome back everyone to the afternoon session. This afternoon we will continue with a highly interesting topic on bone grafting techniques titled a simple GBR technique using tooth derived bone graft. We are honored to welcome our distinguished speaker, Dr. Woong Am, who currently serves as reviewer for the Journal of Oral and Maxillofacial Surgery and the Journal of Oral Implantology. He's also the Director of Research and Development for the Korea Tooth Bank and also the Chairman of the Implant Research Committee for the Korean Association of Oral and Maxillofacial Surgeons. Please give a warm welcome of applause.
Thank you for kind introduction. Good afternoon. So thank you very much for coming in, even right after the lunch. Okay, yeah. So actually, this is the time to take a nap, and you can take a nap. Okay. So first of all, I would like to say thank you, One Day Biotech, for this invitation, and it's my great pleasure to introduce Korea Tooth Bank and our tooth-derived bone graft materials. We are the leading biomedical company in Korea specializing in bone graft materials made from human teeth, extracted tooth. And in the past, we just discussed the extract tooth, but this time we recycling the extract tooth. Yeah. So I'm an oral maxillofacial surgeon in Korea and also under my PhD and training in allogenic bone graft, Seoul National University. Our company, since 2009, I have served as a director of R&D at my company, the Korea Tooth Bank, where I've led innovation in tooth-derived graft materials. Our team holds 10 international patents on tooth-derived graft and published over 100 clinical papers supporting the scientific foundation and evidences for evidence-based implantology. In addition, I've served as a committee member in Division of Dental Implant Research of Korea Academy of Implant Dentistry. So we have developed 4 types of DDM. DDM means demineralized dentin matrix. So we call it DDM materials. Hubity powder. Hubity means allogenic application of DDM, demineralized dentin particles or materials. So Hubity means allogenic application and DDM means demineralized dentin materials. And so powder, moldable, block, and the Hubity supplemented with the BMP. We add BMP on the Hubity powder. All four kinds of materials are approved by the Korea FDA in 2019 and widely used in my country. One important characteristic is the excellent wettability with the blood. Collagen and wettability and the membrane is the key word of this my introduction. So the first half of this hour consists of 4 parts, and while the second half covers the clinical application and clinical cases. First, bone and dentin. Second, DDM and the BMP, the relationships with the BMP, how to supplement the BMP to the demineralized dentin matrix. Third, very important one, why DDM, demineralized dentin matrix, can be used without any membrane. So this is one of the mostly asked questions in this field. And finally, comparison between the DDM and the DBM. Because DBM is allogenic application of the bone graft materials, it is almost the same. The dentin, we process the dentin into several kinds of materials and applied in allogenic. Okay, let's begin with bone and dentin. This is common donor side of the bone graft material. First one is cranial bone, second one iliac bone, and third one rib. They share the same composition and very similar structures, and we call it autogenous bone as a gold standard. So here is dentin, the tooth, except the enamels in the dentin, we have the same composition with the bone, like an hydroxyapatite, organic and inorganic hydroxyapatite, some proteins and collagens like that. In our textbook, in oral histologies, the bone and dentin, here, bone and dentin, the chemically, the composition is almost identical. Only organic and inorganic components, the difference is only 1 and 2% between them. So in terms of composition, dentin is essentially bone. So we found very nice materials, a candidate to make it bone graft materials. Before that, we used a xenograft, bovine or pork, right? An allograft, human bone, and something others. But we found good materials here. So why can a tooth become bone graft materials? First, hydroxyapatite. Here, hydroxyapatite and the collagen, we call it matrix binding proteins, plays the major role of osteoinduction. As you know, all of you know, the osteoinduction is very important in gold standard autogenous bone. And so here, hydroxyapatite fulfills the role of osteoconduction, like similar to a living bones, autogenous bone. And finally, the collagen. Type 1 collagen take on some remodeling activity for a lifetime. So remodel continuously. And here, the osteocalcium plays a major role of mineralization and calcium regulation. So this kind of composition do some induction, conduction, and remodeling, and some calcium regulations. So it's what? It's the same with autogenous bone. So quantitatively, a bone contains slight 25 to 30% more collagen than native dentin. However, after demineralization of dentin matrix, so DDM becomes highly collagen-rich material, nearly 90%. 90% of the remaining structure is collagen matrix. So this makes DDM an excellent biologic scaffold. So the collagen here, type 1 collagen is keyword. And before that, some proteins, growth factors, like a natural bone is also another key word, so we have to remember that. Also, DDM has 3 kinds of pores, spaces: macro, micro, and nanopores. So here the macropores between particles. In between the particles allow blood vessels to migration to about 300 micrometers to 800 micrometers. And the micropores inside the dentinal tubules, we have a lot of dentinal tubules in a dentin, and this allows the fluid and cells migration. 1 and 3, average 1 and 3 micrometers, and 3 nanopores on the surface of the dentin or between the space of collagen fiber. This nanopores on the collagen surface enhance protein and cell adhesion attachment. Together, this multi-scale structures, multi-scale spaces, multi-scale pores create an ideal environment for bone regeneration. So this slide means we have another keyword. What is that? Pores. And the 30 years ago, we need only macropores. And 10 or 15 years ago, we need micropores. But these days, we need nanopores, okay? But the dentin already has all kinds of space already. So we find it. Some my friend asked me, how you invented this kind of material? No, I'm not. I just discovered the materials already. It existed in our histories, but we didn't know that. So when we MG63 cells, osteosarcoma cells, were cultured on DDM at 6 hours, where here it attached. It attached here, so the cells attached and means adhesion on the dentin particles, and 72 hours it proliferated, expanded the number of cells. Proliferation, and 14 days it makes some phenotypic transformation of this fibroblast into osteoblast. So this osteoblast make collagen, new bones, what we call it osteoinduction. Am I correct? So adhesion, proliferation, and differentiation into this is fibroblast, and differentiate into the mesenchymal stem cells. Differentiate into osteoblast and make a bone. That's osteoinduction. We see in histologic evidences, okay? So this type of biological concept was first described by not dentists, by orthopedic surgeons in 1968. Doctor's name is Urist. In 1960, almost 50 years ago. So this is our my animal studies. We just put this material into muscle pouches of nude mice to see what happened in the soft tissues. So we found similar biology processes. Here, okay, this is dentin, some kinds of protein. Of course, this is a bone morphogenic protein. Some kinds of protein released from the dentin through the dentinal tubules. And this induced some mesenchymal stem cells transformed into osteoblast, and this osteoblast make and deposited new osteoid. This is collagen clusters, new osteoid on the surface of dentin. And next, the osteoblast deposited new osteoid and embedded into this osteoid becomes osteocyte. Here, and so we can find some blood vessels in the new osteoid materials, and this will become what? Haversian systems. everything is in the oral histology, okay? So we find the same phenomenon like an Urist. He reported in 1968, almost 50 years ago. So the DDM can be, this is the structure of collagen here, hydroxyapatite, some protein, and fluid. So DDM can be defined as an nanoporous. We have three kinds of pores: nanoporous, collagen scaffold, type 1 collagen containing minerals, hydroxyapatite, and the biologic proteins such as BMP, non-collagenous proteins. It closely mimics the natural bone environment. So that's why DDM, our material, shows strong biologic activity. So the structure in the dentin, collagen, bone morphogenic proteins, or some non-collagenous proteins like growth factors and pores. Okay. Okay, let's move to the second topics, the DDM as carrier of exogenous BMP. In 2010, we reported the first clinical case report using demineralized dentin matrix. Here, put extraction socket, put implant, and graft the powders. After 3 months here, this is implant, defect border, and graft material dentin powder. 3 months after, we found a stable bone formation around the implant and histologically, and so we can get some tissues for histologic examination. This is the dentin. There's a newly formed bone deposited on the surface of the dentin. This is the typical picture of osteoinduction. So our materials in the clinical application, we found the evidence of osteoinduction like this. So this is the first case report. 5 years left after 5-year follow-up. Later, we confirmed the long-term stability and published the result in the Journal of Oral and Maxillofacial Surgery here. So, long-term follow-up, 5-year follow-up result. It's very nice, and some marginal bone resorption or something like that. Dentin naturally contains endogenous BMP. Dentin itself has the BMP, bone morphogenic proteins. In 1991, before that times, they have some animal studies and they found some rat dentin, bovine dentin, rabbit dentin. They found some bone morphogenic proteins. In 1991, BMP was successfully isolated from human dentin. So dentin-derived BMP is slightly different. The structure is slightly different from bone-derived BMP, but their biologic effect, osteoinductive capacity in vivo is the same, very similar. And later studies confirm the presence of multiple growth factors in DDM. This is the recent data showing some TGF-beta1 is the most abundant growth factors in dentin, and here the BMP2 is the second most abundant materials. So this explains why the DDM itself has osteoinductive potentials. So excellent candidate. We have been searching for more than 30 years, 40 years to find the ideal bone graft materials. So dentin, this is the dentin. Already contains endogenous BMP here. Just before, I told you at the beginning, and through processing, we make dentin like this. This type of processing demineralization and some other processing, we just preserve this endogenous BMP. At the same time, we lose the collagen fibers on the surface and enlarge the dentinal tubules. This allows recombinant BMP to bind and physically entrap. So, as a result, the exogenous BMP works synergistically with endogenous BMP. Here, we have three kinds of BMP. If we supplemented with the BMP on the dentins, this is endogenous BMP, natural. So we made a space on between the collagen fibers and enlarged the dentinal tubules, so surface adsorbed, not absorption, adsorbed protein here, and in the dentinal tubule mechanically entrapped protein here, and endogenous protein. So mechanically we have three kinds of BMP because the releasing consequence is very important for osteoinductive bone formation. So remember, three kinds of BMP we have. So this is before loading, we see the widely open dentinal tubules. And after loading, the opening of dentinal tubules are filled or coagulated some materials. Totally different. So this is best materials to carry bone morphogenic proteins. So if we put these materials, DDM or DDM supplemented with BMP, the histologic responses in the muscle pouches of the nude mice. DDM alone here, this is DDM alone, this is DDM with the BMP here, this is DDM BMP. So with DDM alone, here, begins to show expanded dentinal tubules by week 2, indicating by enlarging the tubules, releasing the endogenous BMP or entrap exogenous BMP. In contrast, here, the DDM BMP composite shows much earlier release and much earlier activities. Exogenous BMP is released earlier and inducing newborn. Here, this is newborn formation directly on the dentin surface. So, directly on the dentin surface make a newborn. So, make a newborn and it deposited on the surface of DDM. This is osteoinductive bone formation. What we call this type of phenomenon. This is we learned in the oral histology and development what? Intramembranous bone formation. So we made the bone and just scattered all kinds of bone to the wall of some kind of the walls, like on dentinal surface, collagen. So because it's composed of type 1 collagen, so intramembranous bone. So we can see the intramembranous bone formation and intramembranous bone remodeling under the occlusal forces. So with the graft and with the implant, occlusal forces is very important. So this type of type 1 collagen can stand that kind of forces and go through the remodeling. Okay? So you have to remember one more word. Keyword is intramembranous bone formation. Some bones formed on the surface of the dentin particles. Okay? And 4 weeks after here, The composite not only forms the new bone, this is new bone, but also forms some marrow-like structures. This is bone marrow already in the soft tissue. This bone marrow means it mature the bones development, mature bone development, form the bone by the remodeling. So mature bone forms like this. So what is the bone? At first, corticocancellous bone is the bone. In these histologic sections, corticocancellous bone supported by bone marrow. Okay. So this is a rabbit cranial model here. Then DDM along left side. Bone formation starts from the defect margin here. From here. So from the margins, the bone grows toward the center. In the BMP, bone forms uniformly in the whole field, throughout the whole defect. This shows strong and fast bone formation with the BMP, like this. Here the whole bone formation, here's the radiolucent area. This is DDM. DDM is also osteoinductive, but it's slower than the DDM BMP composite. Histomorphometry confirms earlier and greater bone formation with the BMP. And significant differences can be seen at 4 weeks here. I'm just show you how to understand dentin itself in vitro and in vivo studies. And after confirm that result, we can go to the clinical application. So the role of DDM in membrane-free, yeah, the most frequently asked clinical questions. So everybody asked me about this. Why don't you use the membrane? Yes, membrane itself is fixed, but the material we put under the membrane is totally different. That's the main reason. So the answer is DDM holds blood and cells inside its pore structure because it has 3 kinds of pores: macro, micro, and nanopores. So it stabilizes the clot naturally. Why? 90% of DDM material is what? Type 1 collagen. So everybody has done experience using what? Collagen sponges, right? For hemostasis. Hemostasis means just absorb blood and stabilize the blood, make a clot with the blood, so stop bleeding. Just like that, this material consists of 90% is collagen, type 1 collagen. So I can say it stabilizes the blood clot. So this creates here and protect the healing environment without membrane. Just imagine the extraction socket for orthodontic purposes. So if you extract premolars, right, for orthodontic purposes, you didn't use the membrane. You didn't use any sutures. Just after extraction, just put it some gauze and go home, right? Imagine that kind of healing. Okay. Bone growth, this is a GBR, depend on the both blood supply from the host tissues and the materials, blood wettability. DDM here, no. Absorb blood deeply like a sponge. The sponge is the DDM, DDM is sponge. Same type of collagen and same type of structure. This allows lateral bone growth even without membrane because the blood clot stabilizes outside. Now let's see how these key messages actually works in real clinical cases. So here, we place the implant and pack the DDM. And 3 months, this powder has completely changed, transformed into the newly formed bone. So we cannot see the particles no more visible right here. Oh, I'm sorry. So without membrane, we can make the bone like this, levels and complete transformation. Even without, and after this slide, someone will ask me question. Hey, doctor, when this powder resolve within 3 months, we cannot find the particles, right? So there is no, this is periosteum, no periosteal soft tissue invasion, even without the membrane, right? You see here. So to take a DDM's wettability, another keyword, this slide, wettability with the blood. As first slide, I mentioned the wettability with the blood already, okay? So we apply that kinds of word here in this clinic. So this slide shows not show you the particles, the wettability with the blood. This particle hold the blood and stabilize the blood. That's why we don't use membrane. In the upper clinical cases, we applied moldable powder into an extraction socket. Approximately 3 months later, even it's in the upper side, we observe newly formed bone within the site. So you can do some trap-in biopsy here, was performed to evaluate and histological evidence and followed by implant placement like this. And the lower case shown here, moldable cubit was grafted simultaneously with the implant placement. At around 6 months, we observe here mature newborn completely covers the implant surface. Here, the bone tissue covering the cover screws carefully removed because we do the second surgeries, removed and submitted to histologic evaluation. Yes, this is the trap-in biopsy. This is crestal area. Here is the apex. So this is the soft tissues. Bone body, this is the apex area. Same composition. So trap-in biopsy here, this area show the new bone. This is the bone. Active bone formation with here the Haversian structures. Still it goes into the remodeling process. Yes, almost no dentin particle can be observed. Here, only one here, and just beneath the soft tissues, we could find only one DDM particles. Almost the others particles are resolved, okay? Indicating full remodeling of these particles and newborn formation. Newborn replaced the DDM particles. This is the borderlines of soft tissues here. No soft tissue invasion was observed. Without any membrane with this material, there is no soft tissue invasion. Instead, the tight engage in between the soft tissue and bones means a cellular attachment of the soft tissue and bone. So with DDM particles, allogenic DDM particles regenerate bone and stabilizer of tissues at the same time. Sometimes HUVT materials act as a bone graft and replace the membrane functions. This is the case after extraction, implant and HUVT powder here placed, and the site was simply sutured. Pour sutures like this, and 1 week later, after stitch out, the primary closure was already achieved, like in natural extraction to get healing. Because this powder hold the blood and stabilize the blood, so we see the same phenomenon in the healing of natural extraction socket. See here, this is immediate after operation graft, and 6 weeks after. See the out contour of the graft area hasn't changed. So this material maintains its volume and shape very nice without membrane. See here? And in the central inner side of the graft area, at first it's radio opaque because it has 10 to 15% of the hydroxyapatite, but 6 weeks after, it shows some radiolucencies. What does this mean? Natural remodeling. It enters into the natural remodeling process. So the first step of the remodeling process is activation, and then what? Resorption, right? In between 4 to 6 weeks. So it shows here the resorption activities. Oh, this is already went into the remodeling process. Oh, it's okay, no problem. So the result of this picture say the DDM is not just filling space, it's actively remodeling like autogenous bone, thus making it a strong graft material without the need for extra membrane support. The keyword this is remodeling. This materials goes into the remodeling without membrane, okay? This is vertical augmentation procedure for the upper left first molar here. The vertical defect was treated using moldable DDM after implant placement. Both buccal and palatal defect was successfully augmented. Sorry here. So buccal wall repaired here. On the CBCT follow-up, you can see the defect with the thin sinus floor after implant placement, vertical augmentation here. Vertical augmentation was carried out using moldable DDM. It maintained its volume and shape. At 6 weeks, the graft particles started to resorb within the bone mass. See here, the resorption, radiolucent area. By 12 months, newly formed bone has consolidated and completely filled the defect, and 2 years later, the socket was fully repaired with mature corticocancerous bone. This sequence nicely illustrates the typical biologic cascade of bone graft healing. Transplantation and healing, surface healing, envelope healing, soft tissue healing, and then incorporation of the graft material into host, means union, means in no stability, no movement. Incorporate means just stick to the host tissues. And without any mobility, it goes to remodeling, resorption, and replaced with new bone. And finally, under the occlusal spaces, occlusal forces, some muscle forces, that it goes into the biologic adaptation like this. 유미 선생, time for what? 예? 몇 분 지났죠? 예? 40분이요? 예, 빨리 가겠습니다. In this case, in the lateral central incisor after extraction, the flap was not raised because it has the labial bone defect. On step 2 and 3, we identified the labial bone defect, and step 4 shows the implant placement together with the bone grafting. Step 5, the scat was simply sutured. Here. Who asked me the question, very similar question at the outside before the lunch? Put your hands. Who asked this kind of question? No?
It was a doctor from Thailand.
Thailand?
Yes.
Yeah. Here, thank you very much for remembrance. Here, the sutures, yeah? Simply sutured, leaving with particles partially exposed. Now look at the 5 months follow-up, despite the exposure. Here, where? This is 5 months follow-up, despite the exposure, the side healed just like a normal extraction socket. In the magnified view, you can see that the red particles, one is observed blood, one is didn't observe the blood. Red particles which observe the blood has been naturally incorporated into the natural healing socket, while the white particles which did not observe blood have exfoliated. Right is the collagen plug you use for blood clot stabilization or hemostasis, something like that. So what difference? Here, the particles, here the collagen plug. What difference does it make as a clinical purposes? It's almost the same. Because the particle structure is, as I told you, at the 90% is collagen, type 1 collagen. Now, what is consists of this type of collagen plug? Almost 100% is collagen fibers, right? 5 same collagen, type 1 collagen fibrous structures. So the function is almost same. But this material add one more action is bone graft material. So compare, once more, and we don't need any membrane because it acts as bone graft materials plus membrane activities. Okay? On the CBCT, you can identify the labial defect border. Here, labial defect border, as well as the outline of the graft material. At 5 months, we can clearly observe bone repair progressing from the labial cortical defect border, showing successful regeneration at the graft site. In this case, the patient developed maxillary sinusitis, which was caused by an infection around the upper left first molar after extracting the tooth just before. And you see, you had a lecture about the sinus operation. After extracting tooth, we waited 4 weeks and we went ahead with simultaneous bone grafting and implant placement, both in the sinus and alveolar bone. Post-operatively, the DBM in the sinus was displaced with the fluid and floated within the sinus because the fluid fulfills the whole sinus, so it displaced the graft materials like this. You can see the up floated materials. 2 days after, even with the fluid, the displaced graft returned to its original position spontaneously. The graft repositioned naturally. Why? Because this is collagen. With the solid materials, with hydroxyapatite, it doesn't happen like this. So this is possible because the graft itself is a collagen-based, not rigid hydroxyapatite type materials. Long-term, not actually long-term, 6 months after for the second surgeries, see here, the healings. Follow-up shows successful healings without complication. So the nature of the graft material is totally different. You remember the conventional materials. That's the whole reasons. All together, we don't need the membrane because totally different. So same image of DDM. In the lower, this is DDM, DDM, DDM with different magnification, closely resemble collagen membranes. Here, collagen membrane, membranes, almost the same. Both have collagen-based fibrous structures. This explains why DDM acts as a membrane and graft materials. Case repairing the failed implant and graft on mandibular anterior with Hubit BMP. This is the actual case for the explaining the how to surgically modify the treatment plan on elderly patient. Anyway, so I have failed. There's the implant and bone graft, fistula formation and pus. So we remove everything and repair with the BMP materials. I will show you later with repair BMP materials. See here, graft like this, and about 2 weeks, it stabilized like this without membrane. Here, and about 6 or 7 months, it remodeled some radiopaque mineralized bone, and we could put the implant over here. So CBCT follow-up at 2 weeks, it stabilized without membrane and remodeled successfully 6 months later. So how DDM act versus membrane graft material? Do I convince you? Did I? No? Is it enough for you? Not enough? Yeah, okay. So finally, it's the comparison of the DBM and DDM. DDM, dentin has macro, micro, nanopores. DBM, bone is much denser with fewer pores. More pore means better blood flow and cell migration. So you see this slide. At the microscopic levels, the DBM here has dense collagen like this and cells. The small one is osteocyte, and some have sense systems, blood vessels. So it has osteocyte and endothelial cells because it has blood canals. In contrast here, this is DDM, partially demineralized. DDM has no cells, no vessels. Instead, it's full of nanoporous dentinal tubules. These pores let fluid pass through and give bone cells give a good surface to attach. At first, MG63 cells cultured, the cells attached on the DDM surface because of this type of materials. Yeah? Now the definition of DDM can be a little bit changed, like where? At first, nanoporous collagen scaffolded, so defined acellular, avascular, because we demineralize its acid insoluble nanoporous collagens. So this is a lot of advantages compared to the DBM, which has the cells and blood vessels. In light of this new definition of cellular avascular DDM exhibits certain disadvantages, disadvantages due to its processing method. Here, DBM requires complex decellularization process. Yes, this is very difficult one. It's not complete. Whatever we do, we cannot remove almost all the cells. So this may damage some protein and structure, sometimes cause immune reaction and something like that. In contrast, DBM requires only demineralization, making it more stable and safer than the demineralized bone matrix. So this is the structure once again. Here, collagen sponges, and this is the dentin. What difference does it make? Almost same structures. So it acts as a membrane and graft materials. Okay? Summary of this first half. Yeah. Dentin is chemically almost identical to bone. So type 1 collagen, you have to remember. And structure, we have 3 kinds of pores. So the porosity is its main advantage, and biologic activity means endogenous growth factors in the dentin activate its osteoinductive bone formation, and also it acts as a bone BMP carriers, you see. By that, we can have 3 kinds of BMP on the dentin. And clinical implication, strong clot stability thanks to the collagen, high wettability thanks to the collagen. So it works without membrane, and so remodeling is very predictable, volume stability, as you saw the slide, and the long-term success. So DDM is not just graft material, it behaves like a living bone, protect the membrane activities. Okay, let's go to the second half of clinical application. Where the second one? How many times oh, it's okay, no problem. Okay. So this second half of a simplified GBR technique using a novel tooth derived graft material. Why we call it novel tooth derived? Because it's the world first materials for successful implant outcomes. Bone graft, before going through the clinical applications, remember the humidity is allogenic and collagen-based nanopore scaffold, the keyword. So what the collagen means? Collagen means glue. Glue. So collagen is a glue, adhesive. Okay? It's not just a string, just a glue to produce something very important. Remember one, and due to its unique composition and the pores, this is DDM. You can see the DDM with dentinal tubules, okay? DDM performs 3 kinds of biologic functions, or we have been clearly demonstrated through histological evidences, like this one, osteoconduction. New bone grows from the host bone along the dentin surface or dentin particles. Osteoinduction, bone-forming cells induce mesenchymal stem cells into bone-forming osteoblastic cells, like an osteoblast, and make a collagen fiber. Osteoid bone deposits on where? Dentin surface. So we learned it's intramembranous bone formation compared with endocondylar bone formation. Endocondylar bone formation occur where? Happen to the long bones. Yeah? But here, and the intramembranous bone formation and bone remodeling. Dentin particle is gradually replaced by mature bone over time. So this is new bone formation. Some marrow-like structures, we can find only one dentin particles here. So the remodeling capacity is very fast. Hey doctor, when your material resolved, replaced, within 3 months. Yeah? This is 3 months pictures. So let's see the clinical application from the simple socket preservation and more complex cases here. Defect. Yes, open extraction 4 weeks after. Yeah, this is powder. Just put it. Do not pack our material tightly. We don't need pack the tight. Because that's a collagen, like a sponge, it has to reserve the blood, so we give them a space in between them. So 3 months after we reopen, see the bones completely transformed. The powder, you cannot see the individual powder and defect borders, completely replaced with bone. So this is follow-up. Place the implant and grab the DDM powder into the sockets, and blood easily. You see, and the upper and the first half, blood easily with the particles, so no membrane is needed. At 3 months, new bone forms and the particles are no longer visible, and defect border has already disappeared. The CBCT shows cortical bone forms from the buccal cortical borders up to the implant neck area. At 2 years, 7 months, a thick, stable cortical bone around the implant neck. Thick, stable cortical bone around the implant. Before that, thick cortical bone supported by cancerous bone, a very important one. So this type of unit, we call it bone unit. We call it bone envelope. If we form normal bone envelope around the implant neck, what does this mean? It's a very sound one, healthy one. It's very defensive what? Are you talking to me? No? No? Oh, yes, okay. So, this type of materials make a sound cortical cancerous bone unit is very important. It means it's a strong defense capacity about peri-implantitis. If only we have the cortical bones over there, the cortical bone doesn't have any blood supply. It's a mixed bone. Some half is alive, some half is dead. So it's very vulnerable, very fragile to be impinged by the peri-implantitis. So this is my final goal, to make such an environment around the implant. Almost actually 1 year, 6 months, we can make this type of bone around the implant. Yeah. Simple socket preservation here. The thickness under the 1.5 millimeters, we call the bundle bones. It's relatively quickly resolved right after extraction. So after the extraction, prep and place the implant. Just find the gap between the implant and the buccal wall. This is in Korea, Dr. Om's. My name is Om. Dr. Om's incision. and tunnel the soft tissues to make a space and release the whole flaps. And this is a moldable. Just, yes. Do not pack this tightly. Just let it settle down with the blood like this. And so sutures open. Just the approximation sutures with the incision. Let's see. This photo shows the soft tissue healing from the video case. Dentin hold the blood thanks to the collagen structure, enabling natural socket healing, even with simple sutures, even without any membrane. So soft tissue close completely over the cover screw by 2 months. The incision here on the sound bone promotes scar formation, helping to expand the attached gingiva. It's very useful in the upper anterior and lower posterior. See the hard tissue healing, loose packing of moldable dentin powder between the implant and thin buccal wall, the graft stabilized without tight compression. At 3 months, the particle merged with the buccal bone while maintaining its volume and shape. At 1 year, the volume is preserved and show sign of bone remodeling. In the simple socket preservation case, it clearly demonstrates the DDM can achieve excellent bone formation even without the use of membrane, of course. In all the cases after this, you will see today, no membrane was used even in the GBR or sinus cases.
Can you put the previous X-ray, please?
I'm sorry, I can't hear. Please use them.
This picture is after 1 year,
Yeah.
but I think lingually we have resorption.
Resorption? I don't think so. So resorption means erosion of the bone, right? Okay? Erosion means one component of the cortical or cancerous bone has to be disappeared a little bit, okay? It's a starting point. But in this here, so we see even very thin, the cortical bone, you can see, not actually clear, cortical bone and cancerous bone. So no destruction of the cortical bones, no opening of the cancerous bone. So bone unit, volume unit is still alive, not resorption, it's atrophy.
Sir, no, right now, this X-ray. Where is lingual and where is...
This is the buccal, this is the lingual. You are right. Okay. So resorption means erosion of the bone. One component of bone means cortical bone erosion or some cancerous bone erosion. Okay. So at first, cortical bone has some defect, and then deeper, and if it opens the cancerous bones, it goes very fast. So we call it osteomyelitis. So the resorption or atrophy is totally different. Destruction of the bone unit is very important. Okay, let's discuss later, okay? Yeah, okay. So okay. This is the damaged walls present at the time of extraction. We perform ridge augmentation, not socket preservation, ridge augmentation to expand the bone beyond the anticipated skeletal envelope. This is very important, beyond the anticipated skeletal envelope. So remember, keyword, skeletal envelope. Depending on the damages, the skeletal envelope is totally different, every tooth and every defect. So blood from the exposed cancerous bone, not from cortical bone, blood from the exposed cancerous bone can easily migrate outside the skeletal envelope and contribute to bone formation. Therefore, if we can simply build up the walls to contain the blood clots, the defect could be repaired as easily as in socket preservation procedure just before we sew. Yeah? So to make a wall in this case very easy with moldable type. Because the moldable type, if it's soaked with the blood, it maintains volume and shape. So we can make it very easily. For this purpose, we use, here, sticky moldable tooth powder that maintains its volume and shape and provide excellent wettability with blood. So this video shows how to prepare and apply moldable. Here, this is powder, add saline and mix like an alginate, dab it along the container walls very vigorously, like this, and then it becomes very sticky. And you can mold whatever you want, like a cylinder, cone, or round shape, and very easy to transfer to the defect. Here, the defect on the right upper canine, open here, and slide very light pressure, finger pressure, onto the wall. That's it. It's okay. And then, mold the defect. If you want some suctions, just place the flat instrument over there, and then you can use the suctions to avoid the disturbing the graft. Here. The defect border here, the defect border, right? Backer side defect border was clearly covered with humidity powder, and 6 months. Here, I'm sorry. This is original defect here, defect border, and repaired area with these particles, border and defect area. And 6 months, the graft has resolved and been completely replaced by some tissues, not mineralized, but the powder is no longer visible. And some early signs of cortical bone formation are now evident here in CBCT. So this case shows exposed corticocancerous bone. Exposed corticocancerous bone in a damaged ridge. This yellow dotted line indicates the expected direction of cortical bone regeneration. Anticipated skeletal envelope. The implant was placed like this at the level of the remaining lingual cortical bones, and the exposed surface was patched with moldable tooth graft. Why exposed surface was patched with moldable tooth graft? Exposed cancerous bone means a real defect. If the cancerous bone is exposed, that's the real defect, right? So we have to repair what? Exposed area. So exposed surface was covered with moldable tooth graft, and the CBCT graft material appears radiolucent because we demineralize this material. And 90% of the material is collagen. Only 10%, maybe the hydroxyapatite remained, so it looks radiolucent. And so this material shows its blood wettability, helping stabilize in place. At 9 months, early cortical bone formation is observed. From the buccal defect margins up to the implant neck. At 4 years, 7 months, fully, also you see fully developed corticocancerous bone surround the whole implant neck. Very nice bone formation. This is gold standard. Cancerous graft leads to quick bone formation in the upper side, and cortical graft in the middle undergoes slow remodeling through creeping substitution. Slow, replaced by newly formed bone. Very slow compared to the quick bone formation of cancerous bone. As the lower DDM induce fibroblast and leading to new bone formation. Overall, tooth powder mimics like an autograft. with the same composition and function, osteoinduction, conduction, and remodeling. These are the representative papers we have published on tooth powders. This paper said that we could perform the ridge augmentation because we didn't use any membrane. The ridge augmentation procedure as simply as socket preservation, like a wall defect with promising clinical outcomes as we have seen here by using moldable tooth powder without the need of any barrier membrane. Really? If I use my time, just the same step. When there is no buccal wall, ridge augmentation becomes more difficult and challenging. This is due to the limited blood supply from the thin cancellous bone and exposed cortical bones. To overcome this, we create the buccal wall using tooth block, like this. So once the wall is reconstructed, the space can hold a scaffold for clot stabilization. These tooth blocks are made from the extract tooth and with micropore. We drill the micropore to improve blood vessel infiltration and vascularization for remodeling. Now let's see how to handle the root block during the procedure. This is the block. Rehydration with 5 months, but it's not enough for more than 2 minutes and 7 minutes. See the soft. Sometimes it's flexible. See here, and you can cut with the scalpel or scissors here to make it like a flat form and mold the margins with the instrument. Here. Flexible. So here the buccal wall is completely collapsed. The damaged wall was reconstructed with a tooth block on the buccal side. Osteoinductive powders are used to fill the socket space here. Both the block and powder showed excellent blood wettability, and after 6 months, after 6 months, this complete transformation of this powder and blocks like this, allowing successful implant placement. Yeah. This is upper left canine. Let's see how to repair the lost labial wall with the tooth blocks here. Yeah. Flap open and prepare for the implant and rehydrate the block with the saline to make it soft and flexible, and then cut the apex to adapt it to the implant and then the extraoral side, and place the implant, identify the block, vertically inside the block to unfold, and wrap the labial side of the defect, implant defect. Osteoinductive powders was packed into the minor space between the implant and the blocks. At this time, suture without any fixing materials. Tools, screw, membrane, or titanium meshes. Everybody asked me how to fix the material with the screw or something like that. No. Even the block is also the collagen material, so it absorbs the blood. It's like a sponge, and the collagen itself is a glue, adhesive. So just put it over there, it doesn't move. See the follow-ups here. The labial was repaired with the blocks and osteoinductive powders, and 6 months reopened. See some changes. We couldn't find the block itself. CBCT follow-up, complete loss of labial wall. This red arrow indicates the border of the labia. Cortical defect and the labial wall was repaired with the block and powders. 4 years later, the defect border had completely disappeared. And the newly formed bone, sound cortical cancerous bone, surrounded the entire implant without any marginal bone resorption. Regarding the function of this block, okay, here, the perforated macro holes improve blood wettability, vascular infiltration, and this create or provide space for osteoconductive new bone formation. Here you can see the new bone formed in the macro holes and new osteoinductive bone forms on the surface of the block like this. This is a dentin. So here are the key papers we published on tooth block grafting, and this paper states that tooth block convert the volume defect into wall defect, ridge augmentation into socket preservation. That's the same meaning. So block convert the volume defect into wall defect, work as a bone graft and replace membrane or titanium meshes. This is vertical augmentation. Let me skip because of not enough time. Yes. Even the vertical augmentation, I'm not using the membrane with this moldable type. Yes. See here? Yeah, here. Now let's go to the Hubit BMP. 5 minutes. Okay, thank you. I told you at the first part, the dentin has its own BMP. So this is very important. We have 3 kinds of BMPs. At first, if you graft this type of materials, the BMP on the surface adsorbed in between the collagen fibers release and induce fibroblast in the osteoblast, making new osteoblastic bone formation. And at the same time, the entrapped into the dentinal tubular release and activate osteoclastic resorption like this. And this, at the same time, this osteoclastic resorption released the endogenous BMPs over here, coupling with osteoblastic bone formation. So it exponentially increased its osteoinductive bone formation. So exogenous BMP has some synergistic effect with endogenous BMPs. So this is a prospective randomized controlled clinical trials for each preservation of the Hubit BMP. We reported 2018. The DDM BMP showed appreciable volume stability and high rates of new bone formation compared to DDM itself here and DBBC. BIOS, DBBC. So this is a reference case of BMP. Here the huge defect around the implant and the BMP composite filled the defect with excellent wettability. At 4 months, there was no individual particles and defect borderline due to new bone formation. Complete transformation with newly formed bone. This is the histologic evidences, histologic specimens here from this dentin over the cover screw. That became the cover art of the top-ranked tissue engineering journal in 2020 because this osteoclastic resorption cavity indenting strongly supports provide the rapid bone formation and remodeling capacity of this Hubit BMP composite. So I made all the evidences for these materials and published these articles and see the follow-up. The BMP composite surrounded the whole implant, patching up the labial and crestal alveolar bones. After 3 years, the labial at the lower labial defect border had completely disappeared here, like this, indicating good incorporation of this material into alveolar bone. 8 years later, the sound cortical cancer response complex unit envelope we repaired maintained their volume and shape successfully without any marginal bone resorption. Here 3D images showing before and after 6 years, 7 months. Implant placed with labial defect, labial dehiscence, and Hubity BMP composite applied to cover exposed implant thread. 5 weeks. See 5 weeks. See the complete new bone formation in 5 weeks. I'm also surprised to see this. 5 weeks we made the bone. On CBCT follow-up, labial cortical defect margin before extraction, cortical defect border, composite repaired labial defect, 3 years, mature cortical cancer response around the implant neck. Yes. CBCT shows thin sinus flora and the maxillary sinus cyst. We open lateral window and remove the cyst and some defect on the sinus membrane, but use the prep, implant, and the Woong graft as usual. I didn't repair any repair on the sinus membrane. I just disregard the sinus membrane and replace the lateral cortical plate for the upper part of the implant housings. See this posterior CBCT, BMP composite, and the lateral cortical plate at 1 year. See all the components remodeled and stable cortical cancer response housing is formed around the implant. See what is the major difference between you and I. So this is another case, sinus kidney, Hubity BMP composite packed from the sinus floor to the apex of the implant, lateral cortical plate here was placed over the BMP. Initially there was gap at the window opening. After 4 years, a new cortical roof formed through the Hubity BMP remodeling. And the original cortical plate also underwent clipping substitution. The window gap was fully recovered with sound cortical cancer response. Let's discuss what's the major difference between you and I. And so these are our recent publication on Hubity BMP composite. They reported BMP composite are clinically safe and effective, especially useful in case needing rapid and mature bone formation. Okay, this is conclusion. The key tips for successful GBR come down to 2 essentials. First, transform a volume defect into a wall defect. Volume defect into a wall defect. For this, we use tooth powder and the moldable dentin block, some dentin materials. And second, consider the BMP for severely damaged alveoli of sinus augmentation. So keep it simple, biologic, and effective. Yes, this is 2011 when I visited Woong Hospital. Some doctors and I have done 1 day a symposium for this material. 10 more years ago. Okay. Thank you very much.